Hello, I'm Dr. Debara Tucci, Professor of Surgery at Duke University Medical Center. I have been at Duke in the Division of Otolaryngology Head and Neck Surgery since 1993 and have directed the Cochlear Implant program here since that time. The program at Duke is actually one of the oldest in the country, beginning in the mid-1980s. First, I'll talk a little bit about hearing impairment in the United States. We believe that there are over 28 million Americans who have significant hearing loss, including 1 in 4 over the age of 65. Hearing loss gets to be much more prevalent as the population ages. 10% of those who are hearing impaired are profoundly deaf. The majority of the profoundly deaf people in the United States are actually what we call prelingually deaf, meaning that they lost their hearing before the age at which they develop speech and language skills. Those patients are not ideal cochlear implant candidates, but sometimes they can be considered for cochlear implantation depending on circumstances. The ideal candidate for cochlear implantation is a child born with no hearing or an adult who loses hearing gradually or suddenly over their lifetime after developing speech and language skills. It's estimated, based on those criteria, that about 1/4 to 1/2 million people in America are candidates for cochlear implantation. Worldwide, the problem is staggering. We believe, according to the WHO data, that there are over 360 million people worldwide who have disabling hearing loss, and that's defined as a moderate to profound hearing loss in both ears. 10% of those individuals are children, and this represents more than 5% of the world's population. The majority of those with significant hearing impairment reside in developing countries, and this is due to the lack of preventive care such as vaccines, pre- and perinatal care, and it's estimated that half of those with sensorineural hearing loss do have preventable hearing loss. The incidence of congenital hearing loss is 2 to 4 per 1,000 births in developed countries such as the U.S., but even more at 6 per 1,000 births in developing countries, and about 750,000 children are born annually with a significant hearing problem. The history of cochlear implantation is very interesting, and it begins in the 1950s. A couple in France, DeJourno and Eries, one being a surgeon and the other being a physiologist, devised a scheme to stimulate the 8th nerve, or the hearing nerve, in a patient who was undergoing surgery for a large ear tumor. And it was found that they did stimulate to electrical stimulation and had an auditory percept. That information became known to Dr. Bill House at the House Ear Clinic, and in 1972, he developed the first single-channel cochlear implant device. And that was pioneering work and really set us on the path that we're on today. By the 1970s, later in that decade, the first multi-channel cochlear implants had been developed, first by Dr. Ingeborg Hochmeier in Austria, and then by Dr. Graham Clark in Australia. So both of those devices were early devices on the market. And then, as you can see on the slide, through the 1980s and early 90s, a series of applications to the FDA were approving single-channel, then multi-channel implants for use in adults and then children. And today, we continue to have very significant, profound advances in this technology that makes more and more patients able to benefit. Well, how does a cochlear implant work? And this slide shows something about that process. And this shows the external ear. Oops. Here we go. So here's the external ear. So the cochlear implant includes both an external and an internal portion. So at the time of surgery, we place the internal portion, shown here underneath the skin, and I'll talk about that in a moment, but the external portion is shown here, and that's worn behind the ear. And that contains a microphone, and that microphone, shown here, picks up the sound in the environment. The signal then travels to the speech processor, and the signal is processed and then sent to the transmitter coil that contains a magnet. and that's shown here. That's located behind the patient's external ear and held in place across the skin by a magnet. Then the internal receiver stimulator will pick up that radio transmitted signal from the speech processor and transmit it to the electrode array, which is inserted into the cochlea, as shown here. A cochlear implant evaluation contains several steps, and it includes a medical evaluation, which I do, and an audiological evaluation, which is performed by our cochlear implant audiologist. Sometimes the patient will be seen by her first, and sometimes by me for the medical evaluation first, but both evaluations are necessary very early on in the process to make sure that the patient is a good candidate from both a medical standpoint and an audiological criteria standpoint. So the audiologist performs hearing tests and evaluates speech recognition in a standardized way. He or she will also make sure that the patient does not benefit more from traditional hearing aids than we would expect they would benefit from a cochlear implant. I'll talk more about these evaluations in a moment. We also do a radiological evaluation with a CT scan and an MRI, perform counseling to give patients and their families realistic expectations about what a cochlear implant can and cannot do, and assess their resources and family support. We then, if the patient decides to proceed and they are deemed to be a good candidate, would submit for insurance pre-approval. Cochlear implants are very expensive devices, but most of the time these devices are covered by insurance companies. Sometimes the patient would like to contact other cochlear implant recipients, and we try to arrange for that as appropriate. So the criteria for cochlear implantation are that we expect the patient will be at least 12 months of age. The exception to that would be if a child is born and is determined to be an implant candidate earlier than that, and there's some reason to expect that their candidacy would be compromised by waiting, such as if they had meningitis and evidence of impending cochlear ossification, we might proceed sooner. I have implanted patients in their 90s. We have many very vibrant, active patients in their 90s who really desperately want to hear, and those patients have done very, very well with cochlear implants. Hearing assessment includes hearing thresholds and speech understanding, as would be our typical protocol. Most of our candidates have severe to profound sensorineural hearing loss, but as I mentioned, cochlear implant technology is getting better and better all the time. And part of that improvement enables us to implant patients who have a little bit more residual hearing but still do very poorly with hearing aids. And so I'll talk as well a little bit more about that towards the end of the talk. Our patients have poor speech discrimination ability as well, and that's a critical factor in cochlear implant candidacy. Their typical scores would be less than 60% speech understanding using both ears for sentences in an aided condition. And their scores in a single ear, the ear to be implanted, should be less than 50% speech understanding. So this is typically done in quiet, but also can be performed in the presence of background noise. We have to convince ourselves that the patient would benefit more from cochlear implantation than they do currently from the best fit hearing aids. Make sure that there's no medical contraindication for surgery, although this is extremely rare. For children, they have to have access to oral and oral rehabilitation. The cochlear implant surgery itself is just the beginning of a very long process in children. Children who are born with significant hearing impairment, if they're not implanted or if they cannot benefit from hearing aids, they will not develop normal speech and language skills. So we need to make sure that once the implant is placed, that they have access to educational opportunities that will allow them to take full advantage of the auditory input and learn speech and language skills. And these children who are implanted promptly, typically before 18 months of age, do show that they have a fairly normal trajectory of learning speech and language skills and educational development after the implant is placed. And patients need to have adequate support from their families and realistic expectations about what the implant can and cannot do. For the medical evaluation, I ensure that there's no medically or surgically treatable cause of hearing loss. For a general health assessment, we need to make sure that the patient can tolerate a general anesthetic. The surgery takes about 90 minutes to do in the operating room under general anesthesia. Patients need to be able to undergo post-implant programming and rehabilitation, so they need to be able to come back for follow-up appointments. I also assess their motivation and expectations. A very typical scenario would be that a patient's family, typically an older patient, would bring them in and say, my father is a very vibrant, active person, but he's become more and more withdrawn as he becomes less able to hear the conversations at the dinner table. He can't participate in social activities. Some older patients in particular will become depressed and very withdrawn if they're not able to hear. Recent information has actually shown a relationship between the onset of dementia and hearing loss. And so we believe that people, in order to lead full lives, need to be able to hear, and that this applies regardless of age, as long as the patient is able to undergo the surgery safely. Another part of the pre-implant evaluation is radiological assessment. And so two things that we look for are, is the cochlea normally formed and is it patent? With the advent of good vaccinations that prevent many forms of meningitis, cochlear ossification has become less and less of a problem because meningitis many times can lead to cochlear ossification. And with less meningitis, we've had to deal with that less. But we still do see cochlear malformations on a not infrequent basis. And so these scans show evidence of those two problems. First of all, this is an axial CT scan, a bone window showing cochlear anatomy. And you can see on the left side that the cochlea is normally formed. You can see the snail-shaped structure with the internal septations. On the right side, there's a cochlear malformation. This is somewhat of a common cavity with a combination of structures into one rather than the usual fine cochlear structure. And then on this scan, you can see cochlear ossification. This is less severe on the left side, where the anatomy looks a little irregular in the basal turn, but still patent. And on this side, the cochlea is not patent. So we can implant patients with ossification and with cochlear malformations, but of course in these two cases, we would implant the better formed cochlea and the less ossified cochlea. We can also look at mastoid anatomy to give a little bit of information about how the surgical procedure might go. So in both of these cases, there are nice aerated mastoid cavities, and I'll show you a little bit about the surgery shortly. We also do an MRI, and there are a couple of reasons for this. One is we need to assess the cochlear nerve. So some patients, especially children born without hearing, may not have a cochlear nerve at all, and they may not be good candidates for cochlear implantation. So this is also an axial view MRI showing the cochlea, the semicircular canals, and the internal auditory canal with the contents, cochlear nerve and vestibular nerves going through that canal, as well as the facial nerve. This is a coronal MRI showing the cochlea in a different orientation. So that shows a very nice fluid-filled cochlea that looks normal in its anatomy. The other reason to get an MRI prior to surgery is this, and that's that cochlear implants include magnets, and they will interfere with MRI imaging. So that imaging is not as good quality as it is before you place the magnet for the cochlear implant. Also, having a magnet can preclude patients from being able to have an MRI. And the technology in this regard is evolving very rapidly, so that there's one device now where an MRI is not contraindicated. It's a clever design of the receiver stimulator that actually causes the magnet to rotate within its chamber during the MRI procedure so that it is not influenced by the magnet in the way that other implants are. A couple of the implants, the magnets can actually be surgically removed with a fairly simple procedure prior to the MRI and then replaced, but all of these require some special adaptations and special things that need to be done before an MRI can be done. And so that definitely needs to be taken into consideration with an implant procedure, but it's not a contraindication. The exception to that would be patients with a disorder called neurofibromatosis 2. Those patients have auditory nerve tumors, typically bilateral tumors, and need to be dealt with in a special way, and I'll talk about them a little bit later briefly. There are 3 device manufacturers that are approved in the United States, and they are listed here on the left of the screen. Cochlear Americas is the company that was founded in Australia, and that is the oldest of the commercial companies. Their devices are shown. The external device is shown here at the top, so that's just a view of what their external device looks like. Advanced Bionics was founded in the United States, in California, and that is now owned by Phonak. It was founded in 1993, and an example of their device is shown in the middle. Med-El Corporation was founded by Ingeborg and Erwin Hochmeier in Austria. Their U.S. headquarters are based not far from Duke, and they were founded in 1989 and received FDA approval for use in the United States in 2001, but was used widely in Europe prior to that. And one version of their implant is shown at the very bottom of the screen. And these are in constant evolution. They change on a regular basis. Some of the external devices are waterproof. One company, Med-El, has a device that's not even worn over the ear. It's actually worn just on a disc that fits over the magnet behind the ear. So there are many, many options for patients with different external devices. The internal device is shown here, and that has also undergone much of an evolution. The internal device shown at the very top, this is one example from Cochlear Corporation. So this is the processor. This is the magnet that I spoke about. This particular magnet on this implant is removable with a surgical procedure. This is, I can't see this well enough to tell, but I think this is the electrode here. And then this portion with the little ball at the end is actually an external secondary ground. So that's placed underneath the temporalis muscle behind the ear at the time of surgery. The electrodes themselves can vary significantly. Some of the electrodes are straight arrays that are just placed gently into the basal turn of the cochlea and make the turn around the cochlear spiral as they're inserted. Others are preformed, actually, and these come in insertion devices that straighten them so that they can be inserted just to the opening of the cochlea and then advanced gently into the cochlea and then assume the curve around the modulus of the inner ear. These electrodes can be manufactured in different ways for different purposes. So some of them are specially designed for use in patients with cochlear malformations. Some are used for cochlear ossification, different kinds of split or compressed arrays. The goal of electrode insertion has continued to evolve with our understanding of what's important during cochlear implant surgery. And recent understanding has progressed to perceive that there's a real advantage of preserving cochlear structures. So I think in the early days, not much effort was devoted to doing a gentle implant insertion into the inner ear, but we know now that that's very important. So many of these companies are evolving in their electrode design so that the electrodes can be inserted atraumatically and preserve inner ear cochlear functions for improved performance. This is another example, the Med-El implant. So these continue to evolve. This is the magnet here. This is actually the ground, and then this is the computer, and this is the electrode, just to show you another example of that. The Med-L electrode, as shown here, was developed for hearing preservation. And that means that typically when we do a cochlear implant and a patient has some low-frequency residual hearing, we would prepare the patient to lose that conventional acoustic hearing, and then that would be replaced with the electrical stimulation of the cochlear implant. In recent years, we've discovered that actually if you do atraumatic electrode insertion using specially designed electrodes such as shown here, very flexible but still stiff enough to be inserted, that we can preserve residual hearing. And this is an advantage for patients who have significant residual hearing because that can actually be a help to them. This is what the external device looks like. So in a typical situation, this is the magnet. The microphone is on top here, the speech processor in the chamber, and the implant information then, once processed, is delivered via radio frequency transmission across the skin through this transmitter. And the battery compartment is here. And so what this controls is how the speech information is processed and delivered to the cochlear implant array. So upgrades can be made in the external processor without having to replace the surgically placed internal device. And this can be a real advantage to patients. Typically, they'll be upgraded every 5 years or so. This device also includes the power supply, as shown here. So various numbers of magnets can be included depending on the demand of the patient. The stronger the signal, the faster the batteries are depleted. And so a patient who has a need for a very high level of stimulation might use a bigger receiver stimulator. So what is the speech processing strategy? The speech processing strategy is actually what determines how the sounds in the environment are processed and converted to the electrical signal that's perceived by the inner ear. And the speech processing strategies have evolved over the years. They've become much, much more successful in delivering that information in a way that the patient can use. The speech processing strategies will differ in the number of electrodes that are used at any one time, not the number available, because that can differ between the different devices, but more electrodes does not necessarily mean better performance. The speech processing strategies will differ in terms of the speed at which the electrodes send the information, the number of electrodes being used at the same time, and whether the signal is presented as a pulsatile or an analog electrical signal. This is an early slide from Blake Wilson, who's one of the developers of the cochlear implant. He's one of my colleagues here at Duke. And I'll go through this slide with you. So this shows a speaker speaking a vowel sound. A vowel is a low-frequency sound, ah, and this is the speech waveform that's generated by that sound. This is a 22-channel bandpass filter bank that then processes that signal, and what results is the instantaneous spectrum showing the 6 to 10 largest amplitude outputs of the filter bank. So as I mentioned, this is a low frequency sound, so most of the energy is here in the low frequencies. This is presented to the electrode array. In the cochlea, the base of the cochlea shown here processes high frequency sounds, and the apex shown here processes low frequency sounds. So the instantaneous spectrum selects the highest amplitude outputs and presents those selectively to these electrodes along the array. And as I mentioned, the number of electrodes that are stimulated at any one time can differ depending on the speech processing strategy. This then shows the information stimulating each of these electrodes presented in a pulsatile fashion. And these are offset in time in order to not simultaneously stimulate to adjacent electrodes, which can produce artifacts. So general considerations for surgery when we consider whether a patient may be a cochlear implant candidate, we're aware of the fact that general anesthesia is required. And so in some of our elderly patients, we really need to make sure that they are candidates for this general surgery procedure. And often we'll work with their primary care providers to ensure that they will not have any problems with the anesthetic. We work with our anesthesiologist here at Duke, who also do an assessment of the patient and get any further evaluations that are necessary, such as from cardiology or other specialists. The length of the surgery is about 90 minutes. This is usually an outpatient procedure. In the very young or patients over age 70 or so, I'll generally keep them overnight after the surgery, but typically this is an outpatient procedure. Bilateral cochlear implants are done. Generally, I do them sequentially, but especially in young children, they can be done simultaneously. The ear dressing is removed on the first postoperative day. I'll typically bury the sutures after closure and then put steri-strips over the incision, and those steri-strips will come off at day 10. And then the external components are fit and programmed 4 to 6 weeks after surgery. That'll allow some time for the healing of the wound. The surgical procedure that's followed is very similar to other ear surgeries, such as tympanomastoidectomy. We use a facial recess approach to access the middle ear and the cochlea from the mastoid behind the ear canal. So no surgery is done through the ear canal. The cochlear implant surgery should be performed by an experienced otologic surgeon. We do a lot of ear surgery here of many, many different types, and so this is generally a straightforward procedure, but occasionally there will be anatomy that's unusual or some unexpected findings, and so it's imperative that these be managed appropriately by an experienced ear surgeon. Complications are rare, but they can occur, and so they need to be managed by an experienced team. I'll go through the surgical procedure. So this is an old slide. So this shows a fairly large incision. We typically will use a smaller incision now that really hugs behind the ear and maybe comes out a little bit, so much smaller. But this shows the position of the receiver stimulator using a template. So this is marked out before surgery. And then looking at the bottom portion of this slide, you can see just a view of a temporal bone. So this is the mastoid process. The ear canal is here. This is stylomastoid process and foramen. And then this is the typical opening for a mastoidectomy. And then going further down, this is the mastoidectomy showing the antrum going into the middle ear space. This is the ear canal. And then in between the chorda tympani nerve, which is coming off the facial nerve, and the facial nerve here, we open up into the middle ear space. This is the horizontal semicircular canal. So there are landmarks for all of these structures that are very well known to ear surgeons. Then, looking in through the facial recess, again accessed through the mastoidectomy, we can see the round window, which is the area where the electrode is inserted. So this is the cochlea just shown in relief here. So typically, I will open the round window membrane. If that's not visible, we can also perform what's called a cochleostomy, which is an artificial opening near the round window membrane to insert the electrode. And this is just showing another view. This is showing the semicircular canals, which are beneath the bone that is exposed in the mastoid. This is showing the malleus, the incus, and the stapes in the oval window. And then the electrode is inserted into the round window here to access the scala tympani within the cochlear chamber. This shows the external or the receiver stimulator in situ. This is actually flipped. I apologize for that, but the magnet is out here. The receiver stimulator is here. The electrode is coiled within the mastoid and then inserted into the round window. I will mention that in children, the round window, the cochlea, the facial recess is all normal size at birth. The only thing that grows in a child is the mastoid. And so this electrode redundancy allows for mastoid growth. So there's no problem with the internal device having to be replaced in a child due to growth. This is a schematic of the inner ear, and it shows why we use the approach that we do for cochlear implant surgery. So this shows a cross-section of the cochlea. This is scala vestibuli. This is scala media. This is the organ of Corti. And this is scala tympani. And so scala tympani is where the electrode is inserted through the round window, which is shown here. And the reason for that is because, one, it's the largest chamber. Secondly, it is closest to the neural elements. So this is the organ of Corti. These are the nerves coming through. The spiral ganglion cell is here. That's actually the target of the electrical stimulation of the ear. And so this is the ideal chamber. If there is cochlear ossification, such as with meningitis, this is typically, unfortunately, where the ossification starts. And so it is possible to insert an electrode in scala tympani, which requires a special technique and can result in some good stimulation, but not as ideal as insertion in scala tympani. This is a view of advanced bionics electrode being inserted using an insertion device. So this particular electrode is a pre-coiled electrode, which is inserted through this insertion device. So the insertion device straightens the electrode, and then it's gradually pushed out through this mechanism of the insertion device gently into the inner ear. And this is an example of a cochleostomy. This is the round window, and in this case, they actually opened up in through a cochleostomy. That's a little bit older technique. These days, we insert more typically through the round window, as that's been shown a better mode of electrode insertion. Often in the operating room, our implant audiologist will test the function of the device. So she is able to measure impedance of the electrodes to make sure that the electrodes are functioning well. And she can also stimulate the auditory nerve and record responses from the nerve itself to ensure that the implant is in good position and that the patient is able to process the sound. This is often something that we do with children. Children can be difficult to program depending on their age and their ability to cooperate. And so having information about thresholds and growth of sound can help the audiologist in post-implant programming with children. So she will often come in and measure responses from various electrodes in the array. And this is showing growth of electrical stimulation responses from very low response to a good robust response here at 700. I always have a long discussion with patients before any surgery about potential risks and complications. One difficulty of the cochlear implant is that we currently have no tests that can be used to predict exactly how patients will do with a cochlear implant. And so we have to rely on the patient's history, our experience, and the test results that we can get. And so we typically try to discuss with the patient how convinced we are that they would do better with a cochlear implant than they do with their current hearing aid based on experience and in our test results. And so that's part of a long discussion that we have with the patients. We spend several hours between my evaluation and the audiologist going over all of this information. And so on my end, in talking about the surgical complications, I discuss the risks of anesthesia, the risk of infection, which is very, very low, very uncommon to have an infection because of the implant being a foreign body, but it can very rarely occur. And the concern that I would have in this case is sometimes patients with MRSA, methicillin-resistant Staph aureus, may have some issues with that, and so that requires some special consideration. There's some risk of bleeding. It's very low with cochlear implants. All of the imaging that we do prior to surgery will help us to identify if there's an abnormal course of the facial nerve or other abnormalities in the anatomy that will alert us to the fact that we might need to modify our surgical approach. And facial nerve injury is a risk. The risk is extremely low, particularly if the nerve is shown to be in a normal anatomical configuration, but that's certainly a risk of surgery. Tinnitus is a risk, so anytime you do surgery on the ear, no matter what that surgery is, there's a risk of tinnitus or increase in tinnitus and dizziness. This is surprisingly uncommon with cochlear implant surgery, despite the fact that we are opening the inner ear. And typically patients who do have tinnitus after surgery will realize improvement in the tinnitus once the implant is activated. We know from studies that tinnitus is actually decreased in patients who have cochlear implants in place. And in fact, in some studies in Europe, patients with unilateral hearing loss and tinnitus were implanted to see if it would improve the tinnitus, and it did. Dizziness can occur, and that's usually temporary. Implants can fail. There's less than a 5% failure rate. If they fail within 10 years, the company will replace the device, but the patient still needs to undergo the surgery again to replace the device. And the results are generally as good with the replacement device as they were with the initial one. There can be some problems with connection of the magnet if the skin is too thick or if it's too thin, and the device actually can, in very, very rare cases, protrude through the skin, and so that's an emergency that needs to be dealt with surgically. Further risk can include meningitis. So back in 2002 or so, it was realized that patients who had cochlear implants were more at risk for developing meningitis. And for that reason, a very large program was developed to ensure that all patients who receive cochlear implants are vaccinated prior to surgery. And so I enlist the help of the primary care provider to adhere to the vaccination recommendations provided by the CDC. I have a recommendation sheet that outlines the vaccinations that are recommended and the schedule on which they should be administered. So that includes Pneumovax and also Prevnar. Prevnar is a new recommendation. It used to be a vaccination primarily given to children, but now is recommended for adults as well. Cochlear implant results can be reported in a great number of ways, and one of the ways is by looking just at hearing thresholds. So in almost all patients who have a cochlear implant, hearing thresholds are improved, but that does not translate into improvement in speech reception. And so those are two different measures, and I'll show you more about that at the end of the talk. In children who are implanted, we measure speech reception and production because they need to learn to speak. Language development is measured as well. In children who undergo cochlear implantation, they develop language skills on a similar trajectory to normal hearing children in a delayed fashion. Rehabilitation issues such as school mainstreaming, so we know that cochlear implants in children are cost-effective from the standpoint of education because the vast majority of children with cochlear implants can be mainstreamed in public schools, whereas those who do not have cochlear implants and cannot function in a hearing world would be educated in schools for the deaf, for example, or potentially in special classrooms with interpreters for the deaf. We also measure cochlear implant results in terms of cost effectiveness in other ways. One would be productivity in the workplace, and another would be quality of life. So hearing understanding versus speech understanding is something that I discussed on the last slide. Hearing thresholds are almost always dramatically improved, and that indicates how well environmental sounds are heard. But it does not correlate with speech understanding. And one issue that comes up is adults who are prelingually deafened. So I often will have parents in particular bring children in who were raised in a deaf educational setting, have not developed speech and language skills, but for various reasons there's a concern about safety. So these adults are becoming more independent, but cannot hear alarms, cannot when they walk out on a street, can't necessarily know if there are cars coming. So there are significant safety issues associated with profound hearing loss. And we have implanted some of these individuals. We need to make sure that the family and the patient understands that they won't be able to understand speech. But if we're convinced that this is a significant safety concern, then I think that cochlear implantation is certainly a viable option for them. So after cochlear implantation surgery, we wait typically 4 to 6 weeks, and then the patient will visit with the cochlear implant audiologist for the fitting and programming of the external components of the implant. So before that, you cannot see anything on the outside at all, and then the external components are programmed. And this is an example of a electrode fitting that would be done by the audiologist. And what he or she will do is set each electrode in terms of the maximum level of sound that can be received, as well as the threshold. So that determines the dynamic range of the auditory stimulation, and that's shown in the colored portion of the bars here. And that can be changed, and in fact, there can be several different programs. Patients can have controls that allow them to use different programs in different settings. The same is true for hearing aids, so that's a similar concept. If there's background noise versus one speaker versus sitting quietly watching the television, and there are many, many different devices that can be used with implants to make them more effective. So in terms of counseling, how do we talk to patients about cochlear implants? So as I mentioned, there's no test that will predict performance. Many people have looked. We would love to find a test that would allow us to tell a patient exactly how they will do with a cochlear implant, but we just don't have that. So as a general rule, what I say is that after cochlear implant surgery and programming, patients will continue to improve in their performance, typically over as long as a year. And then looking at the asymptote of their performance, I would say that a third can understand any speaker on the phone. So that's an excellent result. Phone is a challenging auditory environment because you can't see the speaker, and there's some degradation of the signal as well. So that really tells you that those patients function extremely well. A third of all patients can understand a familiar speaker on the phone. So they have a little bit compromised ability compared with the best performers, but they are still, in general, extremely satisfied with their implant and feel that this adds significantly to their ability to hear. A third can't communicate on the phone. And in those patients, it's more typical that their performance is improved compared with before the implant, but they need some auditory cues. And so if they're looking at somebody when they're speaking, the implant really helps them to be able to process the sound, but they can't necessarily perform well on the phone or in other challenging environments like that. Best results are obtained in children who are implanted actually before 18 months of age, but certainly before 3 years of age. So those are kind of the cutoffs, and we very much try to implant children right near 12 months of age. Best results in adults are with immediate implant after onset of hearing loss, if the hearing loss is acute, or in those who have had consistent use of amplification. So results are less good if you have a patient who has a long-standing profound hearing loss in one ear, and they haven't used amplification, at least not recently, and then have some residual hearing in their opposite ear and are using a hearing aid. We have a little bit of a question about how they would do with cochlear implantation in the poor hearing ear that has not been amplified. So we have a lot of conversation around the topic of which ear to implant, when to implant, and that really requires a lot of counseling and discussion. And then again, prelingually deafened adults who don't have speech and language, don't use hearing aids typically, but they do get some sound awareness with the implant, and so that's a valid treatment for them under certain circumstances. Cost effectiveness of cochlear implantation has been compared in some cost utility studies and shown to be of statistically significant benefit in adults, including the elderly, and they looked at age 70, but I would argue well above that. Results are comparable to the treatment of severe angina with angioplasty or bypass surgery, so that's certainly of great benefit. And as I mentioned, for children, there are significant cost savings for mainstreaming education. There are other types of auditory implants as well. This is a very exciting field and evolving very quickly. Auditory brainstem implants are possible in patients who do not have auditory nerves. So those implants go on the cochlear nucleus, and that's something that's been explored for the past many years, actually. Some people are looking at implants in the midbrain of the auditory system. But I'll talk about two particular advances in just a little bit: electrical acoustic stimulation and bilateral cochlear implants. I won't talk about low-cost, effective cochlear implants for use in developing countries, but that's something that I think is extremely important as well. So this shows a auditory brainstem implant right here. So in this case, there is no auditory nerve, and the implant needs to be central to the auditory nerve. And this would be a typical case in patients with neurofibromatosis 2 who have had surgery to remove bilateral acoustic neuromas. It's also being done in children who are born without auditory nerves. So they can be implanted in the brainstem as well, and that's a sort of a new evolving area. But the thing that I think is most exciting actually for the immediate future and has the potential to impact many, many patients is electrical acoustic stimulation. So we know that there are 28 million hearing impaired people in the United States, and the majority of these are not profoundly deaf, and so they're not candidates for conventional cochlear implants, meaning that they don't have across the board, across frequencies, severe to profound hearing loss. Some of these patients have very significant amounts of residual low-frequency hearing. And as you remember, the low-frequency sounds are processed in the apex of the cochlea, which is at the very tip. And so in these patients, it's possible to place a short cochlear implant array into the basal portion of the cochlea where they don't have residual hearing, and also use a hearing aid to amplify what they do hear in the low frequencies heard in the apex of the cochlea. In these patients, hearing aids are typically very ineffective because they have such significant high-frequency hearing that their speech discrimination is very poor. So again, this is a very important new frontier, I think, in hearing healthcare. These patients are described as having a ski slope hearing loss, and so a little bit of hearing in the low pitches, as I'll show you, and then just really drop off. And such an audiogram is shown here. So in this patient, the audiogram is showing low to high frequencies. These are the thresholds, and normal hearing would be 25 dB and up, and this is profound hearing loss down here. So their thresholds are at the level of a mild hearing loss in the very lowest pitch, and then just gradually drop off. So 1,000 hertz is around 90 dB, that's very poor hearing, and no high frequency hearing is perceived. And so this is an example of the cochlea that's unrolled. And so this is the apex where the low frequencies are heard. This is the basal portion of the cochlea where the high frequencies are heard. So this would correspond with the high frequencies. And this is a cochlear implant with the electrode going into the basal portion of the cochlea. So the successful surgery depends on being able to preserve those structures in the cochlea so that the patient doesn't lose this residual low-frequency hearing. And so that requires special surgical technique and special atraumatic electrodes, and that has been a topic of investigation for many, many years now. And so this shows the atonotopic map of the organ of Corti, showing high frequencies here, and then as you go around the spiral, low frequencies are here to about 20 millimeters. So in a typical situation, we would not insert an electrode past 20 millimeters in order to preserve this low frequency hearing here. So in terms of what we can do today, two of the companies have these devices that allow hearing preservation, or at least have been studied. Really, hearing preservation is possible with any of the three devices because we've done that. Cochlear Corporation is now FDA approved for this protocol. Med-El, the second company, is approved in Europe but is currently under consideration for FDA approval. Their trial is completed. And so we know from these studies that it is possible to preserve low-frequency hearing. And what residual low-frequency hearing does for patients is it really allows them to hear better in the presence of background sound and allows them to usually appreciate music a little bit better. So there are certain hearing functions that really benefit from having better low-frequency hearing, and so patients tend to do very well with these devices. A second topic is bilateral hearing, and so as we become more and more sophisticated in understanding what enables patients to perform better with their hearing devices, we have a better appreciation for the importance of binaural stimulation. So what binaural hearing does for us is typically to allow us to hear better in the presence of background noise, and it allows us to localize where sounds are coming from. So if any of you do have unilateral hearing loss, you probably already know that it's very difficult if somebody talks to you to know where their voice is originating from. And cochlear implant patients are no different in this regard. And so in our patients who can benefit still from a hearing aid in one ear, we will implant the opposite ear and encourage them to use the hearing aid in their better hearing ear. And as well, in patients are candidates for bilateral cochlear implantation, then we will also do bilateral cochlear implants if the patient desires. And so this is generally more of a concern for children who are beginning their hearing lives very early in life and need to be able to hear to process sounds optimally. And for adults, particularly adults that are in the workplace, very vibrant socially, for whatever reason, they really feel like they would benefit from bilateral cochlear implants, we will consider that. I wanted to show you just quickly one of our patients. This is a gentleman who has adult onset hearing loss, and he is a retired college president, so he had a very high-profile job for many, many years, struggled with his hearing, was wearing hearing aids. He developed hearing aid in his left ear after radiation treatment for a residual skull-base tumor in the late 1980s. And then the surgery in the left ear, he had surgery in the left ear to try and improve hearing. I don't have any details of that operation, but failed to improve his hearing. And then developed on top of that sudden hearing loss in the right ear in 2011 of unknown etiology. Generally, when this occurs, we assume that there's a virus, a viral labyrinthitis that causes that, but it's really a controversial area. We don't know what causes sudden sensorineural hearing loss. And he was unable to benefit from a hearing aid in the right ear. So this is his audiogram, and it shows, again, from low to high frequency. The thresholds are measured at from low intensity to high. And the red circles are the right ear. So he has a severe hearing loss in the right ear. And in the left ear, he has this sort of unusual configuration of hearing loss. He had no measurable speech understanding on the right, and looks like he had about 52% speech understanding in the left ear. But as you can imagine, looking at this, he struggled tremendously to hear. So I don't know if you could imagine this, but being able to hear only 50% of the words presented to you in quiet in one ear is extremely debilitating. So he really could not function well at all. He was wearing a hearing aid in his left ear and continues to do that. So he was tested by our cochlear implant audiologist in the clinic with his hearing aids to determine if he had good speech understanding in that environment. Words were presented at 60 decibels, And below is shown his sentence understanding with hearing aids, and this is an optimal environment. Still no benefit from amplification, no ability to understand speech at all in the right ear. In the left ear, he was at 39% with his hearing aid, and both ears together, usually the binaural results will be better. Combining the two ears in this case, really not much benefit because there's not really any good function in the right ear. So he was determined to be a good candidate for cochlear implantation. The right ear was selected for implantation with plans to continue hearing aid use in the left ear so that he could have binaural stimulation. These are his results. So as I mentioned, hearing results, so these are his hearing thresholds with the cochlear implant, are at the level of a mild hearing loss. This is pretty standard for most patients, so they can hear pretty well. The implant was placed with a full insertion through the round window using a soft surgery technique, and the post-implant hearing ability to understand sentences in a similar scenario as measured preoperatively. With the cochlear implant and the hearing aid, he's able to understand 61% of the speech delivered to him compared to 40% beforehand. And with the CI, only 44% compared with 0% before the surgery. So this represents significant improvement, and these results are at 3 months after he was implanted. So he's continued to improve. I don't have more current data, but he's really done remarkably well and is so very pleased with his cochlear implant. Feels like it has a tremendous positive effect on his life. In fact, he emails me on a regular basis telling me about it, so it's fun to follow his progress. And the last thing that I wanted to mention is that there are constant new advances in this field, and probably the most recent to come about, even in the past 6 to 12 months or so, is implantation of patients with unilateral hearing loss. And this was pioneered in Europe, and it was done primarily by people who were interested in alleviating tinnitus. A couple of groups noted that some of their patients with unilateral profound hearing loss were more disabled by their tinnitus than by their hearing loss. And so they got special approval to do cochlear implant surgery because we know that in most patients, cochlear implantation can actually improve tinnitus. It did improve tinnitus, and it also improved their hearing. And so we had assumed, I think, beforehand that the cochlear implant signal was degraded enough that if a patient had acoustically normal hearing in the opposite ear, that they would really not be able to utilize the information. But it turns out that they can. And so more and more patients, I think, who are disabled, especially by acute onset profound hearing loss in one ear, have been determined to be candidates. But the caveat is they can't be long deafened in that ear. So the best responses are obtained in patients who have lost hearing within the past 5 years, and especially if they were able to use amplification at all, if they had a progressive loss and now are not able to use amplification but could for a time. And so just to let you know that there are new things on the horizon, and it's always worth an evaluation to see if a patient is a candidate for cochlear implantation. So in summary, this is a very exciting field. This is one of my favorite parts of my practice. I direct the program here at Duke, and I would be more than happy to see your patients and look forward to the future of this field. Thank you.